This is Red Hot Healthcare. Interviews with today's leaders and all the news that matters. Here's your host, Steve Ambrose.
Hello and great to have you aboard. I'm your host, Dr. Steve Ambrose. For past and upcoming episodes, find us on iTunes and most podcast directories, or on our eye-catching website, redhothealthcare.com. Hey everybody, this is Dr. Steve, and I want to thank you for tuning into the show today. It's going to be a good one because we're going to talk about the many perspectives of value in healthcare. We talk about value-based care. What does value mean to the different players involved in the system? So I'll start us off with a power quote here that I thought was appropriate, taken from the Institute for Healthcare Improvement's Dr. Paul Batalden. And he says, quote, "Every system is perfectly designed to get the results it gets." And for me, that quote sets the perfect entry point into discussing perspectives and value. And what better way to start us off than to jump right into the model that brought us here, the fee-for-service model. It's a healthcare reimbursement structure. It's been around for over 50 years. And in fact, even though what we're seeing today is a lot of the fallout, in fact, this matches exactly how the program was designed. To start off with, fee-for-service took away a lot of the risk and expectation for payments that patients had and providers had. Over time, it allowed for greater health consumer access, abilities to get hospitalization services. One of the things also it did was it opened up the medical profession. It really allowed that growth within, allowing for more specialization. It grew the drug and the health services sectors as a whole. But really what happened in the long run was that the growth occurred outside of a normal consumer-based market. So there were no free market industry forces. You didn't have checks on pricing. You didn't have checks on quality. Probably most important, you didn't have the ability for healthcare consumers to make any sort of real impact so that there'd be fair competition. And detrimental effects, including unchecked high costs, skyrocketing prices right now, deductibles going through the roof, co-payments. You've also got more expensive co-payments for drugs. I think coming away from all this, one of the things I realized looking deeper into the history of fee-for-service is really from the beginning there was no clear incentive to improve the quality of care whatsoever. And then if that quality wasn't met, there was no way to actually have any sort of accountability. So let's get back to the beginning. I want to go back in history into the 1960s. And there's some people out there like Dr. Ron Paul who talk about the 1960s, the era just before Medicare, being a golden age for healthcare. And so Dr. Ron Paul is quoted as saying, "It worked rather well, and there was nobody out in the street suffering with no medical care." So let's take the politics aside. Nothing could be further from the truth. We go ahead and tap in with Rosemary Stevens. She's a historian and sociologist at the University of Pennsylvania. She wrote an article as far back as 1996 that talked about this. And she says, quote, "In the early 1960s, the choices for uninsured elderly patients needing hospital service were to spend their savings, rely on funding from their children, seek welfare, hope for charity from the hospitals, or avoid care altogether." Just coming in on another reference point with that, in 1964, the Social Security Administration published a study known as the Survey of the Aged. And this study focused on Americans 65 years and older. Here's what it concluded. Quote, "The cost of medical care is high for the aged, particularly for those requiring hospital care. Many aged persons never recover from the economic effects of a single hospital episode. Even for the insured, there is no present guarantee against dependency in old age caused by catastrophic medical expense." So they talk about those being covered by insurance because at that time, health insurance didn't really cover the full gamut of care services. It covered basic hospitalization. We check in finally with Ron Anderson. He's a professor emeritus of health services at UCLA Public Health. he talks about the people in those days from a survey that was done in 1963. It's a general survey that's done of the population. And because of costs, because of the pricing, essentially, these are all the people who reported not seeing a physician. Those who had pains in the heart, 25% didn't see a physician. Unexpected bleeding, 34% didn't see a physician. Shortness of breath, 35%. Abdominal pains, 31%. Repeated vomiting, 40%. And diarrhea for 4 or 5 days, 38%. You're talking about people, even back in 1963, which decided to forego medical care altogether because it was just too expensive for them, right? Sound familiar? So it's the early 1960s. We've got a situation where many senior citizens can't afford care, and we've got unaffordability even back then. So things turn a bit differently here. And back then, there was an organization, it's still around today, called the Ford Foundation. That time, these foundations, particularly the Ford Foundation, was connected very heavy into the political parties. When you talk about policies that were coming around for health, education, welfare, lots of times what would happen is you would have these well-connected organizations. They do studies. They might even have a political bent, and they would have the ear of the politicians. They would have the ear all the way up to the president. And in 1963, a fast-rising economist named Kenneth Arrow was sought. Now, he was a neoclassical thinker. He published groundbreaking work on competitive equilibrium as the foundation for modern economic thinking. It's way over my head, but essentially the guy was brilliant. And the Ford Foundation tapped him. They basically wanted to know, how can we fix the issue in today's healthcare, particularly with seniors and those that can't afford care? Arrow has no background in healthcare, right? No background in health insurance services. But he wrote a paper, and the paper was entitled Uncertainty and the Welfare Economics of Medicare Care. 50 years later, it remained the second most popular reference work in healthcare economics. This guy, although he had no background in healthcare, no background in insurance, wound up more or less in a de facto way becoming the father of healthcare economics through this one paper. So Arrow sat on President Kennedy's Council of Economic Advisors, later went on to receive a Nobel Prize in economics for non-healthcare related work. But this is very interesting. 1963, in this landmark paper, Arrow explains that the market for medical care was unique because unlike other consumer markets, outsiders could not judge the quantity or the quality of services provided. He concludes this, quote, behavior expected of sellers of medical care is different from that of businessmen in general. Arrow argues, again, at a time when doctors were revered as gods, Arrow argues that patients had to implicitly trust doctors, the presumption being that the doctor's interests would be fully altruistic. They'd be placed with the interest of the patient before their personal motives. And moreover, that delivering health care is completely different than any other free market service, and the only way it could be corrected if there was an issue would be by government intervention. All this comes together. The government adopts this point of view, reads the paper, adopts the point of view, and decides that free market forces couldn't and wouldn't work for healthcare. So this is where the tipping point is, guys, right here. The conclusions lead to, in 1965, establishing Title 18 and 19 of the Social Security Act, and it creates the entities we know as Medicare and Medicaid. Just as a historical point, the first Medicare card was issued to the very first recipient, and you may know this already, it was former President Harry Truman. And at that time, just hang on to your seats, the total cost of Medicare as a participating member was $3 per month per member. That would get you Part A and Part B coverage. and there was no secondary coverage. They went off, they signed up all the country's seniors. I think there were 19 million that were eligible for Medicare. 93% enrolled by the summer of 1966, 11 months later. And Johnson's administration believed that the $10 billion starting budget that Medicare had would easily be more than enough to hold it off because the Social Security Administration was getting all new money, right? It was $3 per person, almost 19 million people, and they just assumed that that plus other monies would more than cover Medicare. It would never hit the budget peak. Now, this is another important point. It really needs to be made clear that as far back as the early 1930s, the American Medical Association, the AMA, was the biggest detractor against health insurance. It was a staunch opponent, and it based its opposition on the grounds of, quote, no third party must be permitted to come between the patient and his physician in any medical relation. So that same mindset, which intermingled the financial, the clinical aspects of healthcare, that was front and center in the 1960s, guys. This is a time where decades of healthcare expansion had already hit, and clearly care was unaffordable. So the social program change was at the forefront of Lyndon Johnson's Great Society. And knowing that the AMA was opposed to Medicare and Medicaid, the government wants to make sure at that time that they have the buy-in from all the doctors. It's important to keep in mind that today, I think it's something like 25% of all doctors belong to the AMA. Back then, it was closer to 70%. I mean, the AMA was a powerful organization, and when it said to do something or not do something, it was going to be universally adopted by its membership. I mean, that's how strong of a hold the AMA had back then. The government knew this, and for this reason, the Social Security Administration had a division called the Bureau of Health. This would be the forerunner to HCFA, and essentially it decided that it was going to pay physicians and hospitals on a profile of fees deemed reasonable and necessary. And it also permitted the physicians and the hospitals to bill the Medicare directly for the services rendered. So now Medicare actually has the doctors on board, and here's the kicker. Not only did doctors have the ability and hospitals have the ability to bill Medicare directly for services, doctors did not have to accept Medicare's fee as payment in full. They did not have to take assignment, if you can imagine, for any patient. So here's Ken Arrow, here's the government, here is the deal that's made where doctors and hospitals essentially are given professional self-control as the only control toward keeping costs down. Guess what happens? Very quickly, the rate of increase in doctors' fees doubles. And some doctors even charge Medicare up to 4 times what they accepted from commercial carriers. That is essentially, in 1966, how Medicare started, the controls on fee-for-service, and this would eventually expand out to other commercial carriers. Let's fast forward to 2017. We have average industry costs in the U.S. They've gone up since 1950. They've gone up about 8 times if you take the average of all the industries. Healthcare costs have risen a mind-numbing 274 times. Spending on healthcare today consumes 27% of the federal budget. It consumes 30 to 40% of the state budgets. Medical bills are the number one reason for bankruptcy in this country, and 46% of Americans now forego needed care. Sound familiar? Just like before 1965, where seniors forewent their care? Fee-for-service and its results, pretty much, guys, they've been widely accepted as broken. We all know this. The healthcare system is unsustainable. And so we have the triple aim, right? We're going to bring down costs. We're going to increase the quality of care. We're going to improve patient satisfaction. We're going to improve care coordination. And now we have the cherry on top, which is fixing physician and care staff burnout. We're all on the value-based care train. Let's get rolling. Not so fast. This week's news on CMS putting the brakes on the bundle programs just hit. It tells me a lot. I don't think it makes Secretary Tom Price or the CMS leader Seema Verma, I don't even think it makes the Republican administration evil or uncaring. I really see it as revealing. I see it as revealing a hidden flaw in our healthcare system, maybe one not hidden, but one that's not often admonished, and that is that the needs of the healthcare system and the needs of the healthcare businesses are simply opposed. And a lot of providers want to see value-based care worked. They can't support it, though, if it's going to trump their own values for sustaining profit. Look, I can't make this point strongly enough. You've got hospitals, health systems, payers, providers, even drug companies. Many of the people who lead these companies, who work at these companies, they have caring motives. They want to see healthcare better. They want to see people better, okay? You've got value-based programs like patient-centered medical homes, ACOs, you got the bundle programs. I've got a lot of colleagues and friends in this space, guys. I never assume that their motives are evil. But let's be honest about a few things here. The primary goal for any for-profit company is to sustain growth and profit. That's it. That's their major value. They may employ people and they may make products, they may sell products, they may have patients and consumers, but their chief motive, their chief value is to grow profit. It's true of all business sectors. Healthcare is no different, or I should say healthcare business is no different, especially if the company has public shareholders. It's really true also in the case of private, even nonprofit healthcare companies. They've got to generate numbers in the black, right? They've got to be able to retain top leadership. They've got to be able to capture administrative and clinical talent. They've got to be able to compete with the for-profit companies. Value-based care, incredibly noble, desperately needed, but let's be honest for just a second with ourselves, if we could. And I'm speaking not just to those consumers out there, but really to the healthcare providers out there. Let's be honest. Look, did a majority of providers ever create or support patient portals, mobile health applications, and did they ever push patients to get patient-generated health data 5 years ago, 10 years ago, right? Did the majority of providers ever make it a priority to engage patients, to make patient experience a top priority that they're going to invest into? They're even going to hire leadership around it? No. The majority of healthcare providers didn't do any of this until portals, patient monitoring, patient satisfaction surveys, outcome results attach themselves into the provider's reimbursement and profit potential, right? Now it becomes important. It wasn't important before, important enough to implement and invest in. It's important now. They didn't want to spend the money on this. They had to spend the money. You get it? It's not evil. It's not mean. And I'm not saying that healthcare providers, payers, and even drug companies don't care about helping their customers and their patients. They do. But the simple fact is, and we've got to realize this, that as a business, the core value, the main objective is profit growth. And that's what's going to allow them to remain competitive and stay in business. Now, if they can do that while engaging in value-based care, then we're going to see a lot less pushback like we saw in the bundles here and the latest news that came out. Here's another great example that a lot of people are not bringing up, and I've spoken about this before in the podcast. Everyone's talking about lowering healthcare costs. Lower the cost for services, lower the cost for coverage, lower the costs in drugs. Now, the presumption here is that, let's say on the provider side, if you lower costs, then payers are going to be able to more successfully transition into value-based reimbursement. So will the providers, right? What's going to happen is you're going to keep the profit margins the same because you drop down costs, then the payers can pay out less. The payers pay out less, still the same profit margin for the providers, right? Maybe even better. So the risk and the shift is going back to the providers in value-based care. They've got to make it cheaper to provide care and certainly better quality. You never hear, like you would in any other consumer industry, that if you lower these costs, if companies lower these costs in part or whole, they're going to pass down those savings in the form of lower pricing to the customers and patients. This is what happens when you remove the full force of consumerism for an entire industry segment. This is what happens when you have fee-for-service. This is what happens when you have regulated pricing. Look, I'm going to give the providers credit. They're using price transparency now. They're pushing quality of care. They're pushing up the patient experience. Everything except lowering prices. And today, that's the biggest value to consumers and patients. And we're going to get into that in a second. So a non-consumeristic market worked great for Ken Arrow, worked fine for the federal government in the 1960s when they made the assumption of reasonable interests aligning for the good of patients. But I think we can safely say that we put that myth to bed, because really without the necessary free market forces in place, healthcare consumers just eventually got hit with hyperinflated costs. They got higher pricing and they got lower levels of quality. Everything that runs completely consistent with a non-consumeristic model. We talked about this in that initial quote. The results are perfect for that model. It never talked about prices or quality. It just simply talked about regulating prices. And look, why would providers, why would payers or drug companies ever want to change to value-based care? Why? I mean, if their main motive is to make profit, and I'm not saying that's an evil thing, that's their main charge, why would they want to change? Now, those that want to change and that are changing, they're putting their consumer and their patient at the center. That's the only way to do it. Everyone involved in this chain in the healthcare system for fee-for-service just passes the costs and the price buffering right down the line. The line always has ended, and it continues to end with the taxpayer, the individual, and with the business healthcare consumer. That's where it ends. That's who supports this system. I would fault the system and our politicians, in particular, for not having enough spine to put a stop to this far sooner. And we've got to ask ourselves, if our political leaders in each state and in Washington, D.C., can they truly solve healthcare's crisis? Or is all they're really doing simply reshifting monies? Are they just allowing health payers to continually serve the same role that in large part helped bring us here with regulated pricing? And specifically, I'll go on record as saying I believe that healthcare is eventually going to hit a bubble. Now, look, if that shocks you, and I'm not being mean when I say this, but I would suggest you take a step back from what could be a mouthful of confirmation bias you have. Take a healthy swallow, because we're about to enter into economic reality here, guys. Overheating business segments eventually have to digest, especially when they carry significant levels of consumer debt. This one, it's been going on for more than 50 years, and the costs just keep getting kicked down the street. We certainly saw that same overheating with the housing bubble. And now we see mounting medical debt with consumers, and pricing just can't stay at current levels. All right, you've got artificial intelligence and automation is entering the picture. And I look at that really as an extension of a free market society, as an extension of a normal business model. You've got to drop your costs down, you got to improve your quality, and you got to improve your scalability, right? And certainly in healthcare, your accuracy. And what are the two largest costs to any businesses? Salaries and benefits. They're earmarked to human beings. More than 25% of all hospital costs come from administration. There's just too much human process and system limitation. Duke Hospital has 900 beds and 1,500 billing clerks. Okay? Look, I'm going to grant you that doctors and nurses aren't going to be replaced by robots anytime soon. But if we can do jobs faster, more accurately, with less cost and even greater patient satisfaction, why not automate? I mean, why not automate more of the back office administration, right? Registration, claims, billing. And that goes double for drug manufacturers. I want to see drastic surges in efficiency and a lot of decreases in cost. And you know what else I want to see? I want to see the breakdown of where all those R&D monies go. It's not just a line item to me. If they're relying on that to justify their pricing, I want to see that R&D transparent. I'm not trying to be glib here, guys. I'm not trying to belittle the hardworking, dedicated employees with jobs. All right, these people matter. But we're in a crisis here. You think about crises in America in the past. You talk about World War II, where we had tire drives, oil drives. You talk about periods in history where drastic changes needed to be made. Shifts had to occur. Unfortunately, a lot of these situations were painful, but this is what happens when you have issues that have been building up for years and years and years. Sometimes there's going to be pain to resolve it, but it has to be resolved. You can't just keep sweeping it under the rug. Otherwise, you get a nasty lump that people keep tripping over, and that's what's happening here. Politicians can't solve this crisis because they have no ability to do it quickly, easily, and in a way that causes the least amount of pain. There's going to have to, unfortunately, be some pain here. One of the things I'm seeing, talking about consumers, is a new consumer report released a couple days ago from CNBC. And it shows for the first time in a long time that the share price of Amazon, the big consumer giant, as well as what's known as the XRT, which is the Retail Exchange Traded Fund, both of those are going down. And even though consumer sentiment and confidence remains high, the fact remains that in May, a report came out from the New York Fed for the first quarter of 2017. Consumer debt levels are now at an all-time high. They're even beyond the 2008 levels, just before the housing bubble. We talked about what was going on in terms of affordability. Now I'm going to deliver on that. The company West, they just released a report on optimizing revenue. I just got the early report here. It hasn't been released publicly yet. But the statistics that they find are sobering when it comes to consumers and patients and how they look at healthcare costs and pricing. Check out these numbers. 79% of patients say affordability is the biggest problem with healthcare. That's almost 8 out of 10 patients, okay? They're not talking about quality. They're talking about affordability, guys. 93% of healthcare consumers believe healthcare is too expensive. 67% of patients say their financial situation makes it difficult to pay medical bills on time, and 95%, nearly all providers recognize that patients may delay bill payments because of their financial situation. So you've got healthcare providers, you've got payers, and they're introducing technology and talking about value-based care, and they're talking about all sorts of quality. We've got better quality and better outcomes. All that's important. But look, very few providers out there are addressing pricing. It's a strong value trigger for consumers and patients. And the important thing is it has to be recognized. Even apart from the current payment model, it's going to allow over time those providers that use it to capture more consumers, more patients. No matter what's going to happen in terms of going to value-based care, one thing is not going to happen readily, and that is you're not going to see prices drop anytime soon. Not from drug companies, not from payers, not from providers. They're not going to just willingly drop them as a whole. So when I talk about pricing here, I don't mean price transparency. I mean working on ways to make care, drugs, coverage less expensive. You've got to gain greater consumer loyalty. You've got to be able to acquire more patients. You've got to improve medication adherence. You've got to get the data from these people. Wrap it all together. If you're a provider, if you're a large health system or a hospital, understand that your reimbursement is going down. There's no way around it. Your reimbursement will go down in the future. You've got to offset this with volume. You have to. Everybody talks about the fact it's going from a volume to value-based care model. Well, that may be true, but volume is still king. Because if you can command larger patient bases, more services, bigger footprints, you're going to have much better leverage if you're a provider. Much better leverage with payers, much better leverage even with other competing health systems and hospitals. And here's the opportunity, and I call this really an opportunity to acquire and inspire patients. Over and above going into your triple aim endeavors, your MACRA, your cybersecurity, the readmissions, patient risk mitigation, all those things are important, okay? I'm talking about health system leaders, providers that are willing to expand their vision. They have to have an active hunger to compete for and acquire, as I said before, more pools of patients, both locally and remotely through telehealth. There's a lot of tactics to support this kind of growth strategy. We're talking about investing in resources, in telehealth, any sort of technology that increases your operational, your administrative, your care efficiency. Smart consumer patient marketing, that's important too. Healthcare providers, large health systems, traditionally they market with their advertising in an image way, just like Coke does or Pepsi, right? We come to us because we have a great brand name. That's fine, but that's not going to win you patients, particularly millennials moving forward. You got to be smart about targeting them. You got to look for growing your patient pool and the services that go into that pool. You got to be looking at strategic M&A activity. Look, you're going to reach lots of people on telehealth, but there's only so much you can do with consulting. You've got to drive some of these people into local centers, and you've got to have a physical space as you continue to grow. So the tip of the spear is telehealth. You got to follow it through with M&A or strategic partnering, right? You've got to be looking, if you're a provider, a large base provider, you got to be looking at integrating coverage and even direct contracting with self-pay organizations. You can't rely on the payers. The payers are the problem. I'm not saying they're going away anytime soon. I'm saying if you sit back and wait for politicians and payers to decide your fate if you're a health system or hospital, you're making a huge mistake. Over time, the smartest, the strongest providers, they're going to be able to transfer a lot of their lower costs and increased efficiency. And I see, eventually, they're going to start going into a more consumeristic model. Why? Because you've got more patients that are paying more of the financial load. Finally, what's going to start happening is we're going to hit this taboo of lowering prices, right? Fee for service, it never has lower prices built into it. It doesn't just happen. There's no consumer checkoff. That's going to start changing, but it has to come as a result of building up volume, building up strength, building up efficiency. And once that happens, once you start seeing providers, health systems start lowering their prices and making it obvious they're lowering their prices, you're going to see a tremendous shift at that point. It's going to be a positive feedback loop. And you're going to see these systems acquiring and engaging more of their consumers and patients. Healthcare is going to essentially set a new series of routes. Maybe it's going to be a blend between a safety net third-party coverage for catastrophe care or high-dollar care or emergencies. And then the other part of it might be utilizing consumerism forces, whether it's primary care, whether it is non-emergency care. Other providers are going to sit back. They're going to wait for politicians and payers to determine their course. And if you're a smart provider, if you're a leader in a health system right now, a leader in a hospital, you've got to have a growth mindset that really focuses on consumer and patient-centered vision. And just to drive it home, we've come a long way since 1966, guys. We've had, half century of winners and losers and accomplishments, mistakes, a lot of money made, money's lost. But all the while, you have different players in the healthcare system. They're all interconnected, and they're making different decisions on value and worth. Our healthcare system and its underlying industry players are, in my opinion, going to be entering perhaps the largest game of financial musical chairs in the history of our country. A lot of players are going to be able to find a chair. Some are not going to be able to find a chair when the music stops. Some might find just pieces of their old chair. But the ones that boldly venture into a new opportunity, they're going to find their chair. They may have several other chairs as well. And as I said before, this is a time for growth and for boldness and delivering efficient, well-coordinated care. Meeting health consumers, meeting patients at their needs and values, and having that empathetic flexibility to recognize how you're going to gain their loyalty and how you're going to get them activated. As more Americans suffer with that greater shift of financial burden, that unaffordability for care, drugs, and coverage, in a lot of ways, it reminds me of the story of the boy and the starfish. The boy goes out onto the beach, sees thousands of washed up starfish, and he's got to get them back in the water before the sun gets too hot, otherwise they'll all burn up. So he throws them in the water, and an old man comes across him and says, "There's no way you can possibly make a difference to all these starfish. You'll never get them back in the water in time." And why would you be doing this? And the boy throws a starfish and then back into the water, looks at the old man and says, well, I made a difference for that one. And that's what we're talking about. When we talk about health consumers and patients that are baking on a hot beach, they're not able to get the care they need. They're not able to have that effective hand-holding and patient coordination and management that they need. They have their life. They have their health being less than it can be, being less than it should be. These individuals need to be reached out to. They've got to have their loyalty competed for. They've got to be captured, capturing their minds, their hearts, gaining their trust, gaining their action. We're talking about a world of expanding reach and service. It's a tremendous opportunity right now. Providers need to deliver these consumers, these patients, back into the cool ocean waters of better health and life. Okay? And as I continue to review opportunities to lead growth, whether that's going to be a health system, a hospital, or a health vendor that calls on health systems, I look forward to finding myself and my future organization knee-deep in that ocean. I thank you for listening to the show. Have a terrific rest of your week, and take care.
You've been listening to Red Hot Healthcare with Steve Ambrose. Subscribe to us on most major podcast directories. For media or business inquiries, reach out to media@redhothealthcare.com. Thanks for listening. This is Denny Colonna. We're out of here.